Good afternoon. I'd like to thank SAGES for the opportunity to present our work today. It concerns transoral fundoplication, and this is a 3-year report. This is my disclosure. I have received honoraria to teach the procedure to surgeons and gastroenterologists. Have not received any honoraria for this particular study. We've submitted the manuscript as required. So the study investigators are 7 centers across the United States, comprising both surgical and GI groups. The TEMPO trial, or TIF ESOFIX versus medical PPI open-label trial, is a randomized, multi-center crossover study with a target randomization ratio of 2:1, TIF versus PPI. We have already reported in 2 prior publications at the 6-month and the 12-month report, and this was primarily comparing the efficacy of PPI versus TIF. This is not the subject of today's talk, but let me tell you, and you're welcome to review the papers, that it did show superiority of TIF in select patients who were not responding to PPIs in terms of control of atypical and classic presentations of GERD. Our goal here is to look at the durability. There's been questions about, great, the results are wonderful, what about the durability? And so this is an attempt at answering this question. We have here initially 63 patients who were randomized initially to the TIF and PPI group. Everyone in the control group received the TIF procedure. So accounting for the patients who were lost to follow-up in the first and second year, 2 reoperations only in a 3-year period, we ended up with 52 patients, or 83% follow-up. The mean follow-up or median range follow-up is 34 months for this study. So our hypothesis was that the elimination of troublesome symptoms will be stable between 1, 2, and 3-year follow-up. The secondary hypothesis were that the healing of reflux esophagitis will also be maintained. The majority of patients will be off PPIs at the end of the study, and whatever improvement we had in distal esophageal exposure would be maintained as well. So all patients had at enrollment troublesome regurgitation and or atypical symptoms while on daily PPIs. They all had an abnormal pH study. They had GERD for at least a year, daily PPI use for at least 6 months, and importantly, patients had Hill grade 1 and 2, never 3 and 4 in our study, and esophagitis grade A, B, but not C and D. And the hiatal hernias were always less than 2 centimeters and a BMI of less than 35. So here's how we assess the patients at screening using the quality of life questionnaires. All of them had the assessments, on and off PPIs, EGD off PPI, and the 48-hour pH-metry also off PPI. You see here how at 1-year follow-up, all the 1 and 2 and 3-year follow-up, all the assessments are done off PPIs, except for some patients who had been back on PPIs and whose questionnaires were therefore done off PPIs. Our endpoint was therefore elimination of troublesome, used the Montreal definition, and the secondary were the elimination of heartburn, reflux esophagitis, cessation of PPI use, improvement in esophageal acid exposure, and patient satisfaction. This is the outcome measures which we used. The RDQ questionnaire primarily for regurgitation, RSI for atypical symptoms, GERD, HRQL for patient satisfaction, heartburn, and we used 48-hour pH-metry, a Bravo system in all patients to assess esophageal acid exposure. This is how we performed the statistical analysis. This is all in the manuscript. These are the baseline characteristics of our patients. They were patients who had a BMI of 28. They had GERD for 11 years on average, been on PPI for 8+ years. Only 2 had short segment Barrett's, and you notice here again, Hill grade 1 and 2, and all of them had a hiatal hernia less than 2 centimeters, and this is critical. So this is the procedure data describing what we had done at surgery. We used a total of 21 fasteners to build valves measuring 2.8 centimeters with a circumference of 290 degrees. All hiatal hernias, when present, were reduced, and the Hill grade, when it was 2, was reduced in 100% cases to Hill grade 1. All patients were discharged the next day, except for 5% for minor issues. This is what a TIF looks like. Those of you who perform Nissen would recognize that it looks very much the same. There were no serious adverse events associated with TIF, never an intraoperative conversion to open, no blood transfusion, no hospital readmission, and no serious adverse events. Only 2 patients in a 3-year follow-up had to have a reoperation, and this was done without difficulty. So here are the results. What we see here, regurgitation score, and that's based on the RDQ questionnaire. Sorry. Looking here at the first column, this is the total regurgitation score for patients on PPIs, and it's 3.0. 3 years out, off PPIs, 0.5. And when you look at this 1 year, 2 year, and 3 year, it is absolutely stable and statistically no significant changes from year to year. Elimination of regurgitation or troublesome regurgitation by the Montreal criteria was achieved in 88% of patients at year 1, 93% at year 2, and maintained at 93% at 3 years. And this is compared versus screening on PPIs. Regurgitation, critically important in a patient population who, when they don't respond to PPIs, most of the time it is because of regurgitation and high reflux. RSI scores, another tough population to handle, the ones with atypical symptoms. At enrollment, you see how, oh geez, sorry. Okay, patients had, so 13 is the ceiling for normality in that particular scoring system. And all patients on and off PPIs were well above that. Actually, we brought patients from a mean score of 22 on PPIs to a mean score of 4, 3-year outs off PPIs. Again, elimination of atypical symptoms was sustained over the years. In fact, and that mirrors what we see with atypical symptoms, they tend to improve over time, and this is exactly what we were able to observe, although, I mean, the tendency is there, although it was not statistically significant. HRQL scores, again, took patients from a mean of 26.4 on PPIs to 5, 3 years out off PPIs. Esophagitis is important. It was found initially 50% patients who were enrolled in this study had esophagitis, and these are the numbers. The esophagitis was healed in 86% at 3 years out, and there was no difference between the 3 years. Cessation of PPI use, obviously all patients were on PPIs at the beginning of the study. That's an enrollment criteria. 3 year out, 71% were completely off PPI. We're not talking here about cutting doses in half and every other day. That completely off PPIs, 71%. The pH normalization rate that we recorded remained in the 40% range for all 3 years. And we looked at, obviously, all patients had, whenever possible, a pH. I'll be done, okay. The percent total time, the pH was less than 4. The improvement that we saw at 1 year was maintained. Reflux episodes, same thing. And the satisfaction, 2% of patients satisfied on PPIs before surgery, 81% 3 years out of PPIs. I need to maybe wrap it up, or?
Yeah, you need to wrap.
So, in conclusion, this study provides evidence that we have durable control of regurgitation, heartburn, and atypical symptoms up to 3 years post-procedure. In a subset of patients, this is critically important to have good patient selection, of patients who have small hiatal hernias and real reflux. The healing of reflux esophagitis and improvement of pH remained stable between 1, 2, and 3 years. And so we believe that in well-selected patients, TIF has proven to be an endoscopic alternative to other GERD therapies. Thank you very much.